afternoon, everyone. I am Tometta Cozart, and I serve as the Multicultural Outreach and Health Equity Director for the Epilepsy Foundation of America. I want to welcome everyone to our presentation today that focuses on increasing awareness about the connection between epilepsy and CVI. We are very pleased at the Epilepsy Foundation to have learned more about CVI through CVI Now. And so we have several colleagues here from Perkins School of the Blind and CVI Now, and they're going to give us some additional information. So if everyone just wants to introduce themselves, even also out there in virtual world, feel free to share your information in the chat, give us your name, where you're located from, and if you want to tell us a little bit about if you have a connection between CVI and epilepsy, we would love to hear it. So there are three objectives for this particular webinar. The first one is the fact that we want to make sure that we actually define the connection between seizures, epilepsy, and CVI. September is CVI month, and so this gave us an opportunity to work with Perkins School of the Blind and CVI Now to be able to raise this awareness. We also want to talk about the impact of seizures and CVI diagnosis, specifically amongst children, and we want to identify resources and support for all families. So before we go and allow our speakers to just introduce themselves, I just wanted to say briefly in terms of the aspect of the multicultural outreach program at the Epilepsy Foundation, that one of our goals and charges really is to make sure that we are being inclusive in our epilepsy community. And that means even when the fact that epilepsy is a comorbidity of another condition. And so we have been able to collaborate with quite a few organizations, and this is our first time being able to collaborate with CVI Now for this reason. And so we really want to make sure that we're helping our organizations to be able to get to those communities that may not be aware that there's resources for both of them. And so this is an opportunity for us to be inclusive in that regard. So we're really happy to be able to have this collaboration, and we want to see more of this going forward. Okay, so with that being said, I am going to start with Allie and allow her to introduce herself, and then we will go to Lacey, and then we will go to Rachel, and then we will end with Dr. Martin.
Thanks, Tometta. My name is Allie Mahady. I manage outreach and engagement at CVI Now, which is in the CVI Center at Perkins School for the Blind. I have a 6-year-old little boy with CVI and epilepsy and an overarching rare undiagnosed genetic disease. And so that's why I'm here today.
Hi, I'm Lacey Smith. I am a parent also to a 13-year-old daughter, Savannah, with epilepsy and CVI. I have my license as a TVI, so I work with students with visual impairments. But currently I am the CVI Parent Community Manager, and I'm supporting families along their journey of learning about CVI.
Everyone, it's just so wonderful to be here. Thank you, Tometta. Thank you to the Epilepsy Foundation. We love talking about CVI, and we love reaching new communities. We really feel that our community is your community is our community. My name is Rachel Bennett. I'm the director of CVInow.org, which is a big comprehensive website on CVI. As you heard from Lacey and Allie, we also do a lot of outreach work and parent and caregiver support, and we'll talk a little bit more about our resources later. I'm also a CVI parent to my son, Henry, who's 12, and I'll pass it to Dr. Martin.
Hi, everyone. First off, I wanted to thank the Epilepsy Foundation for having me today, as well as the team at CVI Now for reaching out and getting me involved with this talk. My name is Dr. Jim Martin. I am an optometrist at the New England College of Optometry, located in Boston, Massachusetts. Much of my work is clinical-based, where most of my work is going to be at the NECO Center for Eye Care at Perkins School for the Blind, where I work with children who have visual and multiple impairments. I also do a little bit of work at our school's main clinical campus, Commonwealth, where I see adults who've had traumatic brain injuries and kind of work on vision rehabilitation with them. But today, I'm super excited to be here to talk a little bit more about cerebral visual impairment, or CVI, and its interplay with epilepsy. So I'm going to go ahead and pull up my screens there. Which slides should be up for everyone? So, yeah. We'll get started, I guess, with a little bit of definitions. And cerebral visual impairment, or CVI, can be defined in a couple of different ways. The literature agrees on this top definition, which refers to CVI as being a brain-based visual impairment, where the damage to the visual pathways is what's causing the visual perceptual issues within CVI and not due to damage to the eye itself. Sometimes we may have a child with CVI who passes a normal eye exam, but still having significant visual impairment to their function, which really leads to the second definition, which expands upon it, further defining what is impaired, the visual perception, the cognition, guiding the movement, and all of those pieces. And this definition is brought by Dr. Gutton from the CVI Scotland.org group, which is incredible. So kind of looking at some numbers, it's estimated that 1 in 30 children have CVI, meaning that this diagnosis is much more common than one would think. Causes of CVI can include a number of things, including lack of oxygen to the brain, inflammation, or any other injury to the brain, as well as premature birth. Risk factors again include prematurity. Risk factors. Risk factors include prematurity, as well as cerebral palsy, seizures, as well as any other injury that's detected to the brain. So really, we're thinking about anything that can cause an insult to the brain that can impact the growth, development, and function. As we know, both CVI and epilepsy are neurologically based. It's estimated that 60 to 78% of those with CVI also have epilepsy, and both have many overlapping etiologies, again, including prematurity, injury to the brain, including infections, masses, or lesions, as well as other neurologic trauma, such as traumatic brain injuries. There's also a number of genetic conditions, such as Engelmann syndrome and Rett syndrome, that can be associated with both CVI and epilepsy. There is an effect of anti-epileptic medications affecting visual function, and this is something I often see in my patients that come through my clinic. Oftentimes we see this being around abnormal eye movements or gaze palsies or the difficulty being able to access certain areas of gaze. We also see double vision or diplopia, as well as overall decreased detail vision or visual acuity. There's many times where we see patients who, once they are able to be weaned off of their medications, we can start to see improvements to some of their visual findings and function. This is why co-management between eye care providers and neurology is very important. Oftentimes, I'm receiving referrals from neurology, and I'm assessing imaging such as MRIs, EEGs, all before the vision appointment to give myself a little bit of an idea of the patient's presentation and what particular things I might be looking for on examination. Similarly, if my patients with CVI aren't being seen with neurology, I like to make a referral to close that loop and ensure that full care for the patient is being accessed. Now that we know a little bit more about how CVI and epilepsy kind of hang out together, we want to jump in a little bit to some more specific difficulties that those with CVI or cerebral visual impairment may have. We know that CVI can affect several different areas of visual function, visual attention, fixation, as well as our ventral and dorsal stream processes. And I always like to bring in this tree of vision pictured here, which really helps process some of these higher order visual functions by stream. So I noted the ventral stream earlier, and this processing is shown on the left side of the tree and is really related to a lot of recognition, recognizing the words, recognizing letters and shapes and things like that. We often call this our mental library, or our ability to kind of commit to mind something that we have seen visually and be able to bring it up later. We also then have our right side, or our dorsal stream, where we look at more things like spatial awareness and location. We also see such things such as visually guided movement or the impact of visual clutter or crowding. And we'll get more into that in a little bit. With all of these different functions, you can kind of liken the patient's CVI experience kind of like a coin slot. For some, where they have attention being affected in one way, where the ventral stream processing is fine. Other times we see that dorsal stream is affected, where the patient may have more difficulty with things such as complexity and being able to navigate safely. All of these can occur to different degrees in different patients, and that's what really makes CVI a spectrum. And a little bit more on this tree, a little bit bigger so we can all see it. A lot of times when we think about going to the optometrist, we think about the visual function, and that's really represented by the very bottom of the tree, where our eyes are seeing 20/20, we have full side vision, full color vision, as well as a healthy structure to the eyes. Of course, as we just spoke, we then go further up the tree into some of those higher level visual processes. I like to break them down to different categories, the first of which is visual attention and fixation. At its most basic level, this is reacting to stimuli, lights turning on and off, movement around it, and having a visual attention and awareness to that happening. How long can a patient maintain visual attention and how far in front of them can they maintain that attention are some things that I'm looking at. Do they tend to look at the object when they're looking at it, or do they tend to do more side peering and not use their central vision in order to engage with tasks that they're looking at? We then have our ventral stream, which again we spoke to a little bit earlier. And I like to dig into here a little bit more into that idea of visual memory. You know, the ability to see something, have been somewhere, have seen a person, and be able to bring it up again later. This can really impact things such as recognition, such as the recognition of objects, the recognition of other people, being able to recognize others by their faces and facial features. Those with prosopagnosia, or the inability to recognize faces, may rely on some other cues, such as hairstyle, accessories, outfits, or even the posture a person has, in order to identify them through that way instead of by the details on their face. I once had a patient tell me they were a little nervous about switching schools because their new school had a uniform and he wasn't quite sure how he was going to be able to tell his friends apart when everyone was wearing the same outfits. Fortunately, we were able to talk about some of these other cues that we could look at, such as hair, the sound of their friends' voices, and things like that. Recognition can also refer to locations and kind of being able to navigate safely. For instance, going to a mall and remembering the route to the food court, or for those in middle and high school who have to remember their route between classes every day. When we talk about the dorsal stream, we also call it this where stream, relating to location and spatial awareness. Dorsal stream dysfunction can be further broken down into different components. And the first one I like to think about is movement and the impact on motion. Some individuals with CVI find motion to be very distracting and have a very tough time processing it entirely. Some other individuals can note that their perception of motion is more kind of like a stop image where the image is here and then all of a sudden it's here and then all of a sudden it's here, rather than being a smooth movement through space. We also see that some patients with CVI have the opposite and require motion to be able to have visual awareness to the object being there. Another area that we see affected is our visual field, or how much we can see off to our sides. We've seen that many aspects of CVI can make the use of vision variable, and the visual field is a common area where we see this in. We've already seen that there can be decreased attention to parts of a full visual field, and some patients with CVI will say that they notice that their usable visual field can change. For instance, say that an individual with CVI turns down the road to a busy street. They might suddenly find that their usable visual field becomes much less and constricts around them. Oftentimes, we can also find that the inferior visual field loss is more impacted, often related to both anatomical as well as neurologic areas of insult. Other pieces of dorsal stream dysfunction include things such as complexity, which I find to be a very big part of CVI. This refers to visual clutter, how many things a person can see at once and it still be meaningful and being visually accessible. Someone with CVI may have trouble finding an object when it's on a busy background or when surrounded by other objects, such as those kids who need to dump out their entire toy box to find their favorite toy. I have pictured here Dr. Christine Roman's complexity cards, which I often use in the clinic, where there is a main photo, for instance, here is our dog, that has to be found in a series of increasingly difficult images to where they finally have to find the dog on the final page, where there's many more things that's occurring around it. Those with CVI may have difficulty being able to visually search and find the dog, or may find that they are more distracted by some of the other options that look similar to the dog. Visually guided movement refers to making accurate movements through space. This picture up top shows several different approaches to kind of grabbing a cup, starting from a very precise grabbing over to the handle of the cup from a more bigger movement, such as needing to go behind the cup and scoop it towards them due to difficulty being able to locate its exact spot in space. I have pictured on the bottom here the Leia puzzle that the Leia post test that I like to do that will kind of look at how patients move through space and be able to figure out orientations as I turn the yellow slot different ways and they have to send the white postcard through. And this has been a little taste of some of the areas that CVI can be affected and how it may present in some of our patients. Overall, my recommendations are always to kind of suspect cerebral visual impairment when the level of function isn't matching the visual measures. Those who are 20/20 with full visual fields should be able to detect objects that are in their lower visual field, even if they're in a new location, versus some of our patients with CVI who may have more trouble with some of those combinations. The medical history plays a large part in the suspecting of CVI, including some of those causes we discussed earlier, including prematurity, brain injury, or other early perinatal events. And finally, cerebral palsy and developmental delays are other conditions that can co-occur with CVI. So as we learned, CVI can really impact many things, be it the visual acuity, visual field, visual contrast, or it may not affect any of those typical measures that we think of when it comes to vision, and instead be more of those higher level difficulties, as we spoke to during this talk. Those who have more dorsal and ventral streams, those higher level difficulties, tend to be what appears within those patients with CVI. And I believe that really speaks to the full spectrum of vision that patients with CVI can present with, and really going from that primary to secondary higher processing visual pieces. I hope this was very informative to a lot of the pieces of CVI, especially how they overlap with epilepsy, and I'm happy to take questions down in the Q&A. Again, thank you so much for having me.
Thank you, Dr. Martin. We're going to get our slides up now so folks can take a beat to process all the great information that Dr. Martin shared.
Okay. Well, thank you, Rachel. So we will start with some CVI Now slides. We already all briefly introduced ourselves, so I know we can have a chance to reintroduce ourselves a little later in this presentation. So Rachel, I'll let you go to the next slide. Okay, so I'm going to talk a little bit about prevalence of CVI in the United States. It is something that Perkins worked with a company called McKinsey & Company to do some prevalence research, and the research was utilizing advanced analytics and medical claims data, and it studied individuals 0 to 22. So really just focusing on individuals under 22, not adults. And what this found was that less than 20% of children were getting a CVI diagnosis, but there are about 180,000 minimum cases of CVI being diagnosed in the US. So what we're really seeing here is that it's prevalent, but not many of the individuals are actually getting the diagnosis, unfortunately. And this is very concerning because the CVI is the leading cause of childhood blindness and low vision. So it's really misunderstood. So that's kind of why we're here. We want to kind of shed some light on it and kind of spread awareness. Go to the next slide. There's also an additional study from the CVI project that found 1 in 30 kids actually have CVI, which is at least 3% of children in a mainstream classroom. So that is like 1 child in every classroom has some sort of CVI related visual difficulties. So it's a lot more prevalent than people understand sometimes. Next slide. So kind of as already discussed, there are some common association conditions with CVI, and of what with the 180,000 that was found in the study that the CVI Center did with McKinsey & Company, 64% of those individuals had epilepsy, and 65% had cerebral palsy, 72% had developmental delay, 23% had autism, and 20% had different genetic anomalies. And that is something that we also see is a wide range of genetic anomalies and genetic epilepsies, such as Angelman syndrome, Rett syndrome, CDKL5, SCN8A, and many others as well. There's the overlap of common structural conditions as well with CVI and epilepsy, such as cortical dysplasias or brain injury, or just perinatal brain injury to begin with is such a big one. And it also commonly co-presents with other ocular conditions such as strabismus, nystagmus, ocular dysmotility, and atypical optical nerves. So it's not uncommon at all to see a child with, or I should say an individual, but an individual with CVI as well as epilepsy and also other ocular issues. Go to the next slide. So we're going to talk a little bit about CVI experiences, and Lacey will touch into the visual behaviors in a little bit later. So I'll tell a quick story about my son, Weston. He is 6 years old. He has an epilepsy and a CVI diagnosis. When he was about 3 months old, he was diagnosed with epilepsy. That was kind of the first thing that was put on our radar. He was diagnosed with focal epilepsy, which later was determined to be temporal epilepsy. With that, that's really all we thought he had. And so we weren't too concerned at the moment. And then later on, it was determined that from his epileptologist as well as his physical therapist, they both were noticing that his vision was not quite, being used in the way they expected it to be used for his age. And so they both put CVI in the radar for us, and we were able to get referred to vision services really early on, which was great. And he got that CVI diagnosis, I want to say around, 8 or 9 months or so. He was targeted to having that diagnosis, and around 1 year, it was officially in the record for him. Weston has an overarching undiagnosed rare genetic disease that did come with brain injuries and abnormalities. He has cortical dysplasias as well as some right-sided injuries to his brain. So it's kind of expected that CVI for him would be there given those injuries. He started working with his physical therapist when he was 3 months old, outpatient, and she just noticed that he was not really engaged. And he's an engaging little boy, so she kind of early on realized something was off with his vision, and she brought some black backgrounds to some of the sessions and just put some lighted up toys for him or some of his favorite toys behind a black background. And we all immediately saw such a change in how he was reacting to some of these therapies, which was something that we just weren't expecting. And we didn't really know much about CVI at the time, but that started our journey for us. And we were able to start putting those accommodations into place for every day for him, whether it be at physical therapy, at mealtime, or later on into school, which was really necessary for him. And in terms of his epilepsy affecting his CVI, when he was younger, the first few years of his life, he had refractory epilepsy and was on multiple medications. And that really, really impacted his vision and his CVI. He would have multiple seizures a day and then sleep for 4 hours after a seizure. And when he'd come out of it and wake up, he was not able to use his vision. Sometimes he was a little scared. He didn't really know where he was. Some of those toys that he used to love after seizures or after sleeping that long, it just wasn't the same for him. We were fortunate enough to get on a different medication regimen, and we were able to wean him off some medications and get him on a new medication where fortunately it began controlling his epilepsy, and we were seeing huge gains in his vision and his CVI. Like all of a sudden we were seeing that he was just interacting with things differently and able to see things in a different way. Kind of with a lot of kids, when they get sick and have epilepsy, that can also be something that affects their CVI. And we still see that with Weston. If he does get a cold or anything kind of small, we notice that it's starting to affect, we worry about seizures at that point because it's high risk for him at that point, but also we start noticing changes in his vision as well. So it's really kind of intertwined, this CVI and epilepsy diagnosis. As Dr. Martin mentioned, they're both can come from injuries to the brain, which Weston definitely has. And so they're kind of, a lifelong thing for him to kind of manage both and understand both. And it can be a challenge to get people to understand both of those diagnoses for him in particular, because he does not speak. And so some of the eye movements that he does, for example, which are just things that he's developed that maybe he likes, are maybe appear to be seizures, but they're not. And so it can be challenging to train people on Weston. Every child really is unique and every child has their own story with CVI. And I think when you add epilepsy to the mix, and if they're medically complex and nonverbal, it's something that does take some learning. And that's kind of what we've spent the last few years doing, is kind of letting people who work with Weston really understand his little intricacies that make him who he is, and really that diagnosis of epilepsy and CVI and how it really affects his vision and his life. And I'm going to let Lacey take over from here.
Hi, as mentioned earlier, I'm Lacey. This is my daughter, Savannah. She's a complex little girl, and she had a very complex entrance into the world. So unlike Allie, my daughter's epilepsy became, or she got that a lot later. So when she was born, shortly after her birth, she was diagnosed with hydrocephalus, and epilepsy is common in hydrocephalus. So Savannah has always kind of had this large seizure possibility cloud over her head. But at the age of 4, she was, she continued to kind of gain diagnosis. So hydrocephalus is at birth. By 8 months, she had a CVI diagnosis. And at 4 years old, she was diagnosed with the ultra rare disease called Ogden syndrome. And in this community, there's also a lot of seizures, whereas I think there's still a lot for us to understand about her syndrome, but it is very common for a child to have seizures in this community, and CVI. So Savannah she's had several EEGs throughout her life. I remember bringing her in when she was younger and not really officially getting a seizure diagnosis, not even telling me that like her brain waves were erratic, especially during her sleep. But at the age of 7, she started having these different eye movements, and we again had an EEG, and she was diagnosed officially with epilepsy at that point. So she has mixed seizure type. She actually has a diagnosis now at age 10 or 10.5 is when she got diagnosed with LGS. So she has mixed seizure types and various types of triggers and various medications. That's kind of part of LGS. And it's made, CVI very hard for her. So she's always had pretty, what I would say is fragile visual skills. She's not always using her vision. She's more into exploring items, being aware of them through touch or sound. So as her seizures increased, we saw her visual skills plummet a little bit more, and she needed more time to rest and recover, as Allie kind of mentioned too, because the seizure takes so much out of a child. And she just started using her non-visual skills, such as like her hearing and touch again, to really understand her world. So, she's really at 13, she's really a multisensory learner. She uses all sorts of compensatory skills to understand kind of, her world and world around her. And in the beginning of her journey, I wanted it all to be so focused on vision. But now I just want it to be focused on her learning. So the more that we really kind of utilize her compensatory skills, the more she is learning. So I'm going to talk a little bit more about just CVI and kind of what we see. So if we can go to the next slide. Yeah. So at Perkins, we look at 16 visual behaviors and compensatory skills to better understand the impact of CVI on a child. So these visual behaviors fall under the umbrella of visual attention and visual recognition, and they're very interconnected. Perkins recently actually launched a new comprehensive and inclusive assessment tool called the Perkins CVI protocol. And in this assessment tool, we look at each of these visual behaviors and the compensatory skills that I mentioned, and we'll mention a little bit more. And Dr. Martin also touched on some of what we look at when we're looking at a child with CVI. Next, thanks. So compensatory skills, again, these are the skills that our kids are using that have CVI to really understand their world. And they include context and memory, predictability, color coding, tactile skills, smell, auditory cues, verbal labels. And one of the examples I like to give about my daughter is, she also has a diagnosis of cerebral palsy. So when we move her to her area, she has she has a context of being in her home. She is very familiar with the area, and she predicts that her chimes that she loves are going to be on the floor, and she'll start swiping for them, even though she's facing up. She's not looking at all at her chimes. She's just predicting that they're going to be there. So that's one of the skills that she's really learned to use, and just her routines in general have really supported her understanding through her compensatory use. So CVI experiences, vision can be affected by internal states such as seizures, fatigue, medication, as we've all kind of discussed, and external states such as noise and clutter and heat. There's so many people that talk about how heat impacts them as well, and other sensory inputs. A lot of our kids have a harder time tolerating a lot of noise or a lot of motion. Vision use is not passive, it's really hard work. And it can be unreliable, especially, as we think about a child having epilepsy and CVI together. And there are just many ways to access information. So it's not just about vision. Some use vision, some use non-visual skills, and many use both. So what might you observe with CVI? A child might look at things differently. They might have trouble looking at something pointed out at a distance, or notice something only when it moves or lights up. They might have trouble finding things or recognizing objects, not notice new items or toys, miss things in certain visual fields, or need verbal cues to find something. They might have trouble interacting with people and only recognize someone when they hear their voice. I know that's how my daughter recognizes me, as my voice. Again, sometimes context and predictability, because she's not able to make that eye-to-eye contact with me. They might not return a social smile, or have trouble making eye contact, or miss gestures like a high five or a handshake. They might tire easily, be overwhelmed when there are too many things to look at, or appear overly tired at the end of the day. And, a lot of parents report that they hold it together at school, and the minute they get home, they're just kind of done for the rest of the day. They might have trouble at meals, so finding food on their plate, eating in a busy environment. They might struggle with school tasks, like appear to have a shorter attention span or not seem interested in learning. They might be reluctant to join a group or to participate if it's noisy or loud. They might have trouble navigating spaces such as tripping over clearly visible things and bumping into furniture. Difficulty going down ramps or steps, like dragging their heels, pausing or tapping their toes to really confirm that, they're safe on the ground. Okay, we're going to hand it over to Rachel now.
Thank you, Lacey and Allie. So these are just some of the ways of some of the different manifestations of CVI. I'm seeing some of the questions in here, and CVI has such a broad, wide range of diverse manifestations, right? Anything with the brain is going to be complex. When you have one person with CVI is one person with CVI, as we say with many other conditions. And so with CVI, often with a diagnosis, or if you suspect, or if your team suspects this at school, it's important to have educational assessments for your child, a functional vision assessment, a CVI assessment. The CVI Center just released the Perkins Pre-CVI protocol, as Lacey mentioned, and also a learning media assessment to truly understand what are the most appropriate accommodations and supports for your child, what's the most appropriate environment, and what are the most appropriate services and programming. I want to go through just some examples of general CVI supports that are really promising practices in the field, and that we are reported to work with many. And so one of the big things we can do is reduce that visual clutter. Clutter is public enemy number one for many with CVI. In this picture here, you can see an example of this background clutter behind the teacher reading. And once you remove that background clutter, you can see how that teacher pops out, right? And so for some with CVI, this may help support visual attention, even recognition, finding where the teacher is. Supportive positioning. For many with CVI, they need to be able to have their body in a really supported position, right? Because that means there won't be as much energy used. And with that less energy, with that supported position, they can then perhaps access their vision for their learning and other sensory channels as well. And then also present materials in the accessible visual field. We heard a lot about visual field deficits with CVI. For some, it's on the right. For some, it's on the left. For some, it's eye level or above. I know for Allie's child, it's below eye level. So it really, again, depends on that individualized assessment to understand what's the most accessible visual field. And you can see even in all these pictures, the reduction of visual clutter, that pop-out effect really have to help support visual recognition and attention. And then intentional use of color. Color is a relative strength for many with CVI. Many rely on color coding to track an unrecognizable visual world. It's a really big compensatory skill. So you see some of the different examples that color is used. Here, color is used to show that there's actually step because this depth can get lost with all one color. Here's a sample meal setup to support, being able to use those visual motor skills. Eating can be a really hard task for many with CVI, as Lacey mentioned. We have color and texture on that light switch, and then also this color green dot to place a remote. We used a red dot in my house for my son, and if that remote is not on the red dot, it's gone. It's nowhere. It's completely lost to him. And so using color to create predictable places to find things can be a really big support. Intentional use of light. Light can be support. It can also be a big environmental distractor. So light coming in from windows, bright light out in the day, even overhead lights can be distracting, but purposeful use of light can support visual attention and recognition. You see task lighting here for this one student. You also see all these other supports in place: reduction of visual clutter, accessible visual field, use of color. And for here, this student using iPads, that backlighting is the iPads can be a popular tool for some with CVI. You can also see this reduction of visual clutter. This is a worksheet that was adapted to go onto the iPad. And then also thinking about the larger environment, so reducing noise, distracting movement, and just other distractions in the environment that could interrupt vision use and even sensory channel use. It's really about the brain's ability to take in that simultaneous information and sensory input. And for many with CVI, there's just that lower threshold. So quiet environment and a less distracting environment can support better access to learning. And so it can support vision use, it can support use in other sensory channels, because once that CVI brain becomes overwhelmed, it can be really hard for many to access their vision, to access even other sensory channels, and you'll see shutdown mode or CVI meltdown mode. And again, in these pictures, you see so many different examples of the supports I just spoke about: reduction of visual clutter, accessible visual field, using many different senses and modes for learning. And lastly, as Lacey mentioned, a multisensory support is just paramount. We know that vision is not reliable throughout the whole day. And so what can we do to make sure learning is accessible throughout the school day for all of our students? And so many of our students are dual media learners. My son is learning both print and Braille. Some are both print and audio readers as well. So again, knowing what works for your child, taking their lead, and putting all the supports in place they need to have their full access for learning. I'm going to close with resources and supports that we have on cvinow.org. Our goal is really to empower parents and caregivers and professionals with comprehensive and trusted resources, tools, and services to advocate for and support individuals with CVI. We have a lot of different resources that are linked here about just introductory resources about what is CVI and when to suspect it. We have a growing Perkins CVI doctor directory of doctors who know about CVI and who can evaluate it. Currently, there's a lot of work going on in the field right now, thanks to researchers and clinicians like Dr. Martin, who are leading the way to spread CVI awareness within the medical field. We have a whole guide around the CVI visual behaviors that look at some more observational questions of what those behaviors look like, and also some sample accommodations. We have an assessment guide, an IEP guide, an early intervention guide, and loads of CVI stories from adults with CVI and other CVI families as well. We also have a new resource about CVI and epilepsy, talking a little bit more about what we're speaking at today on CVI Now, and I believe that was also posted in the chat. We also have a lot of options for parent support. We have a really rich and nice and wonderful big group on Facebook. It's a private Facebook group that we moderate. And so it's just wonderful discussions where you can ask your questions and get really meaningful answers. We also do one-to-one parent calls led by Lacey. So if you really need that one-to-one support and really just dive in and talk to what's on your heart and what you're concerned about, we have that as well. As well as downloadable resources to share with others in your team. And that about wraps it up, but we really appreciate this time to talk about CVI, to talk about CVI and epilepsy, and there's been a lot of questions, so I'll pause here and we can dive in.
I want to thank, I'm sorry,
Go ahead. No, go ahead.
I just wanted to say thank you so much for all of your information. We really appreciate you guys giving us that overview. As a mother of a toddler, it's always empowering to be able to get more information about her development, about things that I should be looking for, and things that I should be talking to about in terms of her milestones with her pediatrician. So as being a parent, I always feel that I want to be as empowered as possible to go in and advocate for her. And so being able to have the words and the knowledge to understand what I'm seeing at home, that I can convey it to a clinician, is always wonderful. So this is one of the reasons why we always wanted to make sure that we put people before our community, that they can share each other's stories. I'm sure there's other parents too who are able to say, okay, that's how I see that too. And now I have kind of the words and the language to be able to use that. So thank you again to everyone. We have had several questions in the chat. We also, of course, are asking people to use the Q&A function, though, so that we can actually type in your questions or responses if need be, because some of them may be a little, again, too technical or medical for us to be able to answer here. We always want to make sure that people know and understand that you should, first of all, have a care team. And so if you're hearing some of the things here that you're realizing that you may not have a provider or a specialist that can help you in that way, let us help you to be able to connect someone who can get you the information that you need, because a care team is what is going to help you to be able to make sure that your children are getting the care that they need. This is another reason why we were very happy to be able to work with CVI now, the Epilepsy Foundation, because they came through our helpline. And so now we are able to actually embed their services and their resources into our helpline. And so that's another opportunity for us at the Epilepsy Foundation, that we want to be able to have as many partners and collaborators as possible. So if your organization too provides services in this regard and can support this community, and we are not connected, please do connect with us at the Epilepsy Foundation so that we can embed your services into our 24/7 helpline. All right, I do see some questions. I think we've answered quite a bit of them as well. We do have also one of our colleagues, Dr. Alexander Van Spybrock, who is a spina bifida expert in Los Angeles. He was in clinic, and so we weren't sure if he was going to be able to join us, but he is actually in the chat, and I see him answering questions. And so we are so grateful for him to be willing to do that.
There's a question that came through the Q&A about color in the iPad. Should I just go into that, Tamara?
Sure, if you see a question, yes.
What background color did I say for iPad? Just in general, iPads are a good low vision tool for some with CVI because of that backlighting, because there's so many ways that you can adapt, a worksheet, which for the most part are not accessible for many with CVI. And you can add color and all the different accessibility tools to make it much more accessible for our students. There's a question around, does CVI contribute to triggering seizures? I'm not going to answer that question.
I'm more than happy to kind of jump up on that one. And typically, no, CVI itself doesn't contribute to seizures, but I have had several families come in and say that CVI, some of the CVI behaviors they were seeing were thought they were seizures at first. So I last week had a patient who every time they were in a new environment just got really tight, a lot of high tone, and the family was like, oh my God, they're having seizures every time we bring them out. But EEGs were completely clean and everything was looking really good over time. So they're like, well, what are some of the next options? So that tends to be more of the route that I personally see.
Yeah, and for what I see, I mean, the most common triggers are things like viral illnesses. Any extra stress on the body tends to lower your seizure threshold and tends to lead to more seizures. The other thing that I see a lot is kids are a moving target. They're growing so quickly especially during adolescence, that you can outgrow the dosage of your seizure medications pretty quickly. And then also the effects of puberty, when there's those massive changes in hormones, that tends to lower your seizure threshold as well. And so sometimes you have to make a lot of adjustments during that period of life. And once again, I apologize to the audience. I created a presentation for this webinar that was too simple for the audience, and I made a mistake about that, and that's my fault. So I really apologize for not having my slides available for everybody.
Oh, no worries.
No mistake at all. Yeah, none at all. So we, again, want to make sure that we are answering as many questions as we can. So if you guys see any that I have missed, please do let me know.
I do want to add on that CVI can cause stress and anxiety and increased fatigue. My son has chronic migraines, and so definitely CVI triggers. It can cause and make him more susceptible to all of that pain. So it adds. We hear so many from adults with CVI, but how much it can really have a whole body feeling of being in an inaccessible environment, feeling tired, feeling stressed, feeling pain. So.
Yeah, and adding on to that, if somebody has sleep disordered breathing, which can be common in a lot of these genetic conditions that have CVI associated with them, and then they're not sleeping well, and now they're lowering their seizure threshold as well. Asking, do I need a pulmonary consult? Do I need a sleep study? Things like that to investigate that and get better sleep help may help with the seizures as well, and thus help with the vision.
I love that. Yeah.
I just want to add in something too quickly that I was thinking about as everyone's kind of speaking. Light is important to a lot of our kids. It's not to all, but if your child does have epilepsy and they can't see flashing lights, that needs to be stated before you start working with, a lot of different professionals and educators, because, sometimes you might think we're going to pull out this light to see if you'll follow it. But if that light flashes at all and can be triggering for a seizure, I think it's just something that parents have to advocate and be aware of.
Mm-hmm.
Absolutely. I'll add that that's something that I speak with several interns who are learning to become optometrists. And that's the first thing I teach them on day one is anytime we're using a spinning light, you ask the parent or caregiver if that is okay to use. So that's something that we absolutely ingrain and make sure that they're aware of.
So there was a question regarding the aspect of like spectrum. As we know in epilepsy, there's a spectrum and there's the epilepsies, right? So for CVI, is that the case as well? Is there levels to CVI? I think that's what the person is asking about.
We definitely see a spectrum of CVI, kind of like I spoke to earlier, that kind of, coin slot metaphor where every patient who might have CVI may have a different presentation of it. So some patients may be more affected by the movement and clutter aspect, while other patients are totally fine with very big visual clutter in new environments, but can't process that motion correctly. So there has been, historically some, assessments that kind of do levels, but I tend to kind of qualitatively kind of see what their CVI, how it's affecting them, so that way I can provide the family and care team some more specific recommendations to help the areas that the patient themselves are experiencing, and not just kind of making it overgeneralized recommendations.
Yeah, every child is so unique, and the spectrum of this problem is just so massive when you think about the complexity of the brain and all the different genetic, associations and things. So it's very difficult to sort of pigeonhole a general population and say this is what they have, because everybody's so different. You just have to look at all the strengths and abilities of each kid.
Exactly. And that's why that educational assessment is really important, because you see the real world functioning of CVI across educational settings and environments, to understand, what are the barriers to access, what are the strengths, what are the compensatory skills being used, and then you can really build an accessible programming from there. But, some of CVI read print, some of CVI read Braille, some prefer auditory. There's so many different manifestations and preferences, like both Dr. Martin, Dr. Spivak mentioned.
Yeah, and just being aware of the changes that can happen over time. You may sort of initially have sort of a pure CVI problem without any ocular disease, but then as things happen and things get, these kids can get the same thing that other kids get in adolescence. They can get keratoconus or a misshapen cornea that now affects them that way in a visual way. And so sort of always being aware, like, what's going on in the eye as well as what's going on in the brain as well.
Exactly. And many with CVI have co-occurring ocular conditions.
Mhm.
Yeah. And you have to think about those, how those progress, or not progress, but change over time, as you said. And yeah, puberty is what we're dealing with right now. And it's just, ooh, quite a beast, quite a beast. All right, we'll keep going.
All right, I know we are getting close to time. And the Epilepsy Foundation, of course, wants to remind you of our resources as well. So if we can just have our closing slides. And while I'm waiting for those to come up, if any of our speakers wanted to make some closing remarks before we let everyone go, our webinar is going to be assessed by the survey that you see on the screen. So if you want to go ahead and take that now, that would be great. We invite you all to do that. But then, yes, I would love to hear some closing remarks from a couple of our speakers.
Thank you all for joining us and learning and your questions about CVI and thinking more deeply about the prevalence of CVI in the epilepsy population.
Absolutely, just echoing Rachel's thanks. It's been wonderful kind of talking with you all and kind of getting to make those connections a little bit more. And hopefully as we continue on, we continue to increase that awareness of CVI and all the different conditions that it intertwines with.
Yeah, I would say a very similar thing as well. It was great to be able to connect with everybody and have a safe space for people to connect about epilepsy and CVI. And I know Tametta's mentioned all the resources that Epilepsy Foundation has, and CVI now has lots of CVI resources for families as well. So please reach out if you feel that you'd like some more support and resources.
Yeah, thank you, everyone. I was just going to say exactly what Allie did. We have tons and tons of resources, and we'd love to help support you along your journey.
Tameta, there's a few more questions. We can answer those offline if you want to share those with us.
Sure, we definitely will. And again, if there's anyone that I missed your question and I wasn't able to get to it, please forgive me. Again, we're just trying to make sure we're respectful of everyone's time. And so in terms of that 24/7 helpline that I mentioned before, that number, of course, is 1-800-332-1000. And it's, again, 24/7. And we are continuing to add resources such as CVI Now.org's organization resources in addition to Perkins School of the Blind now that we're connected with them as well. But in addition to that, if you still have very specific questions about needing to be connected to a neurologist or being able to be connected to a specialist, if you do have a comorbidity with your epilepsy diagnosis and you need more information, please don't hesitate to reach out to us. It is our job that we take very seriously in terms of being able to make those types of connections. We also want to make sure that people understand that if you want to be a more in a bigger part of our community per se, please reach out to us in terms of the aspect on the community and the advocacy side as well. So we have our affiliates that are around the country so that you can be connected to us on the local level and participate in walks, participate in advocacy. We are trying to push for seizure-safe schools around this country, so that even if your child does maybe not have CVI, but if they're living with epilepsy in a school setting, we want to make sure they have as much support as possible. So there's many, many ways for people to get involved in the work that we're doing. And I think that we have maybe one more slide. Yep. And so that's about the aspect of support groups. And so this, again, is another opportunity for you to be able to find your community. And we know that there's a lot of intersectionality in terms of the aspect of what community means, right? So you could be a part of what is happening with CVI, but you also can be a part of some of those other groups that are happening focused on epilepsy. And so we welcome you with that as well. So please join us at our support groups website and find if there's a community for you that you can be able to join. Is there one more slide? And that's it. So yes, so we want to say thank you to everyone. We also want to make sure that the survey link is sent out in the chat and to everyone who registered, in addition to the recording. And so if you have colleagues or even some of your providers that may want to listen to this as well, please share that recording with them, and then they also can reach out to us too. So I want to say thank you to everyone. We really appreciate you, and we will let everyone go. Everyone have a great day.